meeting of the Senate Finance Committee to order. And Senator Susie, I think you've got something to talk to us about.
And I'm hoping that I will be quickly in and out, given the important issues that follow me, but this issue is important enough to introduce an amendment. So I'm Donna Susie, I represent Senate District 18, and I appear before you today to offer Amendment 1873 to House Bill 1678. This truly is a simple amendment. Right now, the New Hampshire Canadian Trade Council hosts a series of events that are to promote education and networking. The state provides an appropriation each year. The issue is that it's been primarily a back and forth with Quebec, where we have attended events in the Canadian province, they've attended events in New Hampshire. There is some interest in looking at some of the maritime provinces as well. And the Secretary of State has requested that in order to facilitate that, we create a fund that would be administered in Treasury, much like was done recently with the fund created for the Ireland Commission as well. I did speak to the Secretary of State. He is away this week. He did submit a letter for the record. I won't read the letter, but he essentially summarizes that we like to host these events, and it at times requires a little more funding. This does not ask for an appropriation. This does not cost anything. This merely allows for the setup of this fund in the Treasury so that the Secretary of State, on behalf of the Commission, could accept a contribution, for example, to sponsor a dinner or to pay for a speaker at one of the educational courses, and it would then be expended out of that fund. So the Commission does a lot of work promoting collaboration between the U.S. and Canada, specifically New Hampshire and Quebec, and as I said, hope to expand to the Maritimes as well. And with that, I would conclude my testimony and be happy to answer any questions you might have.
Thank you, Senator. Questions from the senators on the committee?
And you do have a copy of the Secretary of State's letter, Mr. Chair?
Okay. Yes.
Do you? If not, I'll gladly leave mine so it can be circulated. And okay.
Okay. Senator Bradley, you had a question?
It's come to our attention that the underlying bill, I think the supporters of the underlying bill would like it to go clean to the governor if we're inclined to pass it. So would you be willing to work with us to find another vehicle if necessary?
Senator, I would be happy to work with the committee to find another vehicle so that both the underlying bill and this amendment could be passed.
Any other questions? Seeing none, thank you very much. From New Hampshire Hunger Solutions. Come on up, Brody.
Hi, my name is Bertie DeShays from New Hampshire Hunger Solutions. I'm here to speak against the amendment, specifically because of the process. As Senator Bradley mentioned, we'd like this bill to go by clean. We had a very close vote in the House, and part of the reason for that is there were more Democrats that day than Republicans. We don't anticipate that happening again, so the fear would be if you sent this bill over to the House side, we may run into an issue with being able to have the votes to get this amendment passed and the underlying bill. So we're hoping that the Senate can unanimously pass this out of the committee through the floor and send this to the governor's desk, and we can have a wonderful signing ceremony with some of the co-sponsors and sponsors. So thank you.
All right, questions from the senators? Seeing none, that being the last person who signed up, online, well, I guess online I've got the original bill and not this amendment, so. Oh, that's the amendment? All right, 14-1. Support. Anyone that's changed their mind wants to speak? Seeing none, thank you very much. We'll close the public hearing and we'll open the next hearing in just a minute. You're going to do the bill? All right. right. We'll, ready for the next hearing is on Amendment 1593 FN, and I'm told the governor is out in the hall. Come on in.
Thank you very much. Good to see everybody. All good? All good. Great.
So far.
Well, thank you guys, and I appreciate everybody's spending a little bit of time on this amendment. It's a critical amendment, and I wanted to have the opportunity to come down and talk a little bit about it as our office, the governor's office, took the lead in kind of doing an attempt to negotiate a revision of the Met-DISH agreement. That previous law that was signed in 2018 does have a timeline on it. It is expiring, I think, as a lot of folks know. So we tried to find some sort of agreement and negotiate with the hospital association as a whole in terms of what was appropriate, understanding that there are a lot of variables have changed. First and foremost, how we allocate these funds has drastically changed. The federal government, to not get too wonky about it, is requiring us to move away from our previous DISH model of payment more to a directed payment model. And so when we look at the different formulas, what we're proposing today puts more dollars, millions of more dollars, into the New Hampshire Hospital Association's membership with all the hospitals and the healthcare organizations that comprise the hospitals. How that is allocated within the hospitals, some may get more money, some receive less money. And what we're proposing in this amendment, I think one of the most important pieces of this amendment, what it does is it recognizes that there is a new model of healthcare out there, a more community-based model. And I think the most important part of this amendment is the 9%. And we'll talk about the different percentages here. But the 9% that focuses and ensures community-based access to and uncompensated care assistance in areas of mental health, in the SUD world, in areas of our federally qualified health centers that are seeing a greater proportion of demand on their system as well. No longer are the days where everyone just rushes to the emergency room when they're sick. The traditional, that might have been the way they did it years ago, but the opportunity I think that we have with this amendment is ensuring that those other providers, ensuring that those other really critical opportunities in our community have a bite at the apple, the uncompensated care apple. So I'm going to get a little wonky and take everyone a little bit of a step back. There was a settlement agreement in 2014. That agreement was turned more into a law in 2018. Because there was pending litigation at the time in 2018 that was negotiated between the legislature, ultimately put into the budget and my office as well. And because there was pending litigation, the state, I think, did the right thing. We erred on the side of caution, and we gave a very good deal to the hospitals. There's no doubt about that. In fact, it gave about well over $30, $40, $50 million more than the 2014 settlement agreement. So they started off with, I think, a very good deal. And again, we had the funds to do it. We had the ability to do it. The federal government allowed us to do it, and it has worked well. Moving on, and that agreement effectively said 91%. That's the key number here. 91% of the total funds after you apply the tax, you match the federal dollars, 91% gets returned to the hospitals in a formulaic fashion. We're proposing to keep that exact same 91%. And because of the way that the formulas work, it's actually more money today than it was, or will be more money in 2025 than it was in 2023. The numbers actually go up in aggregate, which I think is a real opportunity. But again, the key piece is then to say, okay, well, the hospitals, as we all know, are in active litigation against the state. They've actively said they do not want to participate in mental health as they traditionally did. They've actively said they want everyone out of their emergency rooms in 24 hours. Okay, if they're going to actively say that they are going to abdicate any sort of responsibility in terms of mental health care, which we know is the crisis, I mean, that is the healthcare crisis of the day right now, then the ability for us to guarantee that 9% into mental health and those federally qualified health centers that do a little bit of everything. God bless them. They're out there. They do dental, they do mental health, they do referrals, they do everything specifically for the low-income community. And then obviously you have the needs as it all ties into the SUD community, treatment and recovery, and making sure that we have guaranteed funds for those folks as well is really, really critical. We started out lower. I started out negotiating well below the 91%. They wanted 100%. That's what they wanted, every dollar back to the hospitals. Oh, and by the way, we're going to do less on mental health. So that was a complete non-starter, obviously. I came back and said, look, let's find a middle ground. Let's keep it where it is. 91%, it's actually more money in aggregate to your system. The numbers that do we have the spreadsheet? So I'm going to have Harold, if you don't mind, pass out a spreadsheet. And the number one question everyone asks is, what happens to my hospital? What happens to my healthcare organization? The spreadsheet that's being presented to you shows a history as well as a future projection of where each hospital has gone with their DSH allocations, Met DSH allocations, and where each hospital each hospital conglomeration is as well. So in other words, Dartmouth, for example, has multiple hospitals in there. When you add it up, they make more money. At the end of the day, there are a couple different independent hospitals as well as the Concord Hospital total, which is less by a few $100,000. But again, the opportunity is securing 30 to 40 million of that 9%, not to the hospitals, but to some of the most critical community-based services. This is an opportunity, I think, that all these dollars have to go to Medicaid. What doesn't go to the hospitals have to go to some sort of Medicaid-based support system within the healthcare system in itself. And a way to guarantee that these community-based organizations and community-based health, which we made a huge emphasis on, it's kind of the one shot that we have to really do it. I mean, we can keep them as line items in the budget, which we obviously will, but to actually guarantee some of their dollars are huge. I'm going to go back to the mental health piece because that's really the driver for me. As a lot of folks know, we've been focusing on mental health here. This body, the legislature, the Senate, has done a phenomenal job making huge investments in mental health over the past few years. The Mission Zero program coming out of Health and Human Services has been absolutely critical. More beds at New Hampshire Hospital, buying Hampstead Hospital, so we have specific and direct care for children. Community-based crisis stabilization centers, our care traffic control coordinator that now coordinates where the available beds are throughout the state. The expansion to funds to our mental health clinics themselves. And now, again, with this new litigation, we're doing everything we can to make sure that we get, it's called Mission Zero, because we're trying to make sure there are 0 people waiting in emergency rooms. A week ago, that was down in the single digits, and I commend the Department of Health and Human Services has done a phenomenal job with that. I think with the new crisis stabilization centers coming online, we'll have even more success with that. So we've done a tremendous work, in no small part due to this body and to the funds that are available. But again, the hospitals are suing us, saying within 24 hours, if someone comes into our emergency room, get them out. Not our problem. Now, I think that's wrong in itself, and we're not here to debate that because I don't think it requires any debate. I think it's an absolutely wrong position to take. Mental health is health care. I think everybody has a community, it needs a community-based approach in that process. But then to come to the state and demand even more dollars and more dollars and more dollars, yet say they're going to do less and less and less, is just wrong. This is an opportunity, again, to secure funds for these other very critical community services. I think they get more money. These community-based services get locked up with opportunity and financial opportunity for the future. You know, I was talking to the federally qualified health centers earlier. There are some that used to actually get dollars that would flow down from some of the hospitals, would flow down to the federally qualified health centers. That doesn't happen anymore. It happens to a couple, but a lot of them have had those dollars completely dry up. And if you look at the chart that I presented, just to give everyone some perspective, in 2017, this deal gave the hospitals $215 million. Last year, $280 million. That's, again, $40 million over what was ever projected. So when folks say, well, we're losing money, they're not losing money. They were given a golden deal in 2018, absolutely golden deal. And we're actually offering to use that as a baseline. And they just want to go up from that. So to say they're losing money, I think is completely inaccurate. When you look at how much in the far right column, each of these healthcare systems, most of those numbers are all in the black, you'll see. They're all getting more money with 5 exceptions as systems. That's a really key, I think, important piece here. And we're talking, I get it. I think, again, I'll bring up Concord. That's the one I see might be hurting the most. They're down $680,000 Out of 280 million that we're putting into the system, they're down 680,000. There's a lot of other ways to make up those funds and create opportunity, but the system as a whole is getting a lot more money here, a lot more money. So again, I'm pretty passionate just about the opportunity we're creating for the hospitals, the opportunity we're creating for the community-based organizations, the opportunity creating for all these ancillary healthcare systems that need more supports, that need more helps, and that have been really delivering a result, specifically in that low-income, uncompensated care world. We already provide more money in DISH back to the hospitals than any state in America. At the highest amount of DISH spending in proportion to total Medicaid spending in the U.S. We're already doing that. So when the association comes and demands more and more and more, it's tough. It's tough to hear because there's so many other needs that are out there. So that's it. I mean, it's a very complicated, wonky process, but it's very critical and important because this is what's going to be lasting, not next year, but potentially 10, 20 years down the road. And I think setting the marker, ensuring that the hospitals get what they need, but also ensuring that those community-based services get what they need. It's a great opportunity to really strike the right balance. I'm happy to take questions or go away quietly or whatever it is. I know it's a lot and it's kind of late in the legislative process. I totally appreciate that, but again, that's why we just want to make ourselves as available as we can in terms of the details. And I know folks from HHS, Henry Littman, who's done a phenomenal job on the Medicaid side. Henry's the one, the brains behind a lot of the numbers you see here. He's worked with a lot of folks trying to what we call smoothing it out. The federal government does not allow us to say, well, you'll get this and you'll get this. Like, I can't push more money into Concord Hospital without the whole system, driving tens of millions of dollars potentially into the whole system. The federal government doesn't. I would do that in a second. That'd be great if we could do that. But the federal rules don't allow that. So I think Henry has kind of stretched it as far as he can in terms of smoothing it out to make sure that we minimize any of the negative impact. But as you can see from that, there's 5 organizations just to the tune of a few $100,000 that are down. Everybody else gets an increase in dollars, sometimes millions of dollars, as well as guaranteeing under this amendment money to the mental health centers and the federally qualified health centers.
Okay, thank you, Governor.
You bet.
We're going to let Henry go last to do cleanup.
Yeah, sure.
But
He can correct my
imagine
math.
the senator's not taking this opportunity to quiz you.
Of
So,
course.
questions from the senators. Senator Bertzel. He did ask whether it had to be limited to the bill.
Whatever you want. Anything at all. I'm open.
Thank you, Mr. Chair. Thank you, Governor, for taking my question. Do you believe that the feds would support the new allocation of the monies?
100%. We follow all the federal rules. I mean, that's the trick. Yeah.
Follow? Of these hospitals, I know you said that most of the hospitals want them out within 24 hours, the mental health cases. So are any of the hospitals on this list or any of the hospitals in New Hampshire, are they still taking care of any of the mental health issues?
Well, sure. Well, if you check yourself into an emergency room, they'll keep you in the emergency room. There's a date coming up where we have to hit 0, technically, or we get penalized in some form by the courts because of the hospital association and all the hospitals suing us, saying within 24 hours, this isn't our problem anymore. So right now, there are individuals that might be in an emergency room beyond 24 hours. It's literally in the single digits on any given day. I don't know what, as of Monday, I think we hit 7, but sometimes it might go up to 11 or 12. You never quite know. We have new crisis stabilization beds that will be coming online just in the next coming months that allow us a much easier opportunity to pull these folks out. It used to be 70, right? I mean, we used to have 70 on every given day. We've literally got it down 90%. So with the new crisis stabilization beds, the 2 new additional wings at New Hampshire Hospital that have now come online, and as well as compounding with Hampstead Hospital that focuses specifically on kids. And then you add the millions of dollars that you guys gave for the new private mental health hospital that'll be breaking ground in the Manchester area in about a month. Those are all pieces that are going to keep us moving in the right direction to hit 0.
But all of those hospitals are required to pretty much, at some point, going to be only allowed 24 hours, and that's it.
Well, no, they could choose to pick them over, to hold them over 24 hours and give them treatment. The court is allowing them not to choose to do that. Yeah.
Thank you.
Other questions from the senators? Seeing none?
That's it?
I think
Okay,
they're letting
great.
you off for easy, Governor.
All right. Thank you, guys. I really appreciate the time. Thank you, sir.
Okay. There are a number of people who are signed up, but several of you apparently are not used to the Senate way of doing business. So no one has checked the box that they want to speak. All right? So I'm going to assume you all want to speak, all right? And we're going to start up at the top, but we're going to bring them, anybody that's got two. We got the Hospital Association. You have two people here. Come on up, and we'll let you both sit at the table together. Scott? Don't leave him there alone. I mean, if you're both for the same organization, I'm bringing you up together. All right.
There's three.
Then I guess I add another chair.
Okay.
All right. Good afternoon, Mr. Chairman, members of the committee. For the record, my name is Steve Ahnen. I'm the president of the New Hampshire Hospital Association. I'm joined by Scott O'Connell, outside counsel from Holland and Knight. You have my testimony, so I just ask that that be made a part of the record. I want to just start by reminding everyone of the commitment that New Hampshire's hospitals have to the patients and communities that they serve. I'll share a report and a number of documents that describe the depth and breadth of that commitment. Last year, hospitals provided nearly $600 million in community benefit through subsidized care, free care, programs in the community, whether that's food assistance, helping vulnerable populations get home visits or get to appointments, substance use services, mental health services, a number of things, whether it's grants to local organizations and many others. And this committee of all knows all too well the commitment that hospitals have to their community. Last year, during the budget debate, where this legislature and this committee particularly invested historic rate increases for Medicaid providers, hospitals came to this committee and to the legislature and we said, don't give us rate increases. Why? Not because we didn't need them, but because it was important that other community providers, like mental health centers, like community health centers, long-term care providers, and others, got larger increases so that they could do more to recruit and retain staff so that they could care for patients. That was good for the state. It was good for those providers. It was good for those patients. We were proud to do it, and we thank the legislature for doing that. And we'll share that. And if you'd like additional copies, be happy to provide those. So let's talk about the amendment that we have in front of us. The New Hampshire Hospitals Association is in strong opposition to the amendment before you because it upends the partnership that has existed between the hospitals and the state over the Medicaid Enhancement Tax and Disproportionate Share Hospital Payment Program. And this proposal would financially harm hospitals and their ability to serve all of their patients across the state. As we've heard, the Met has been the subject of controversy over many years, which was settled just about a decade ago after two superior courts found the tax to be unconstitutional. The hospitals and the state entered into negotiations and did so in partnership to provide for a stable Medicaid program for both the hospitals and the state and our patients. As the governor noted, in 2018, hospitals and the state negotiated an agreement but to enhance funding to support hospitals and raise rates from some of the lowest Medicaid reimbursement rates for hospitals in the country. After the 2018 agreement, according to the data from the American Hospital Association, that increase brought New Hampshire's reimbursement rates to hospitals to 46th in the country. 46th in the country in 2023. Hardly a rich deal. But again, while not perfect, that agreement provided stability for the Medicaid program, for the state, and for our hospitals, and ultimately the patients and communities that we serve. The tax, the Medicaid enhancement tax, it's a 5.4% tax on hospitals' net patient services revenue that generates hundreds of millions of dollars for the state Medicaid program. Last month, just literally 1 month ago today, hospitals in New Hampshire paid $320 million in Medicaid enhancement tax that supports the Medicaid program. When that $320 million is invested in the Medicaid program, the federal government matches it with another $320 million. Without that initial investment from the hospitals, the state would have to look to the general fund to fully fund the Medicaid program. And it's important to remember, 91% of the tax that hospitals pay comes back to them in the form of dish payments and other payments. Not 91% of the total that gets generated with the federal match. 91% of the tax comes back to the hospitals. It's like I'm taking $1 out of this pocket and I'm putting 91 cents in this pocket, and we're paying everybody out of that 91 cents for the uncompensated care they provide. That's not a rich deal by any stretch of the imagination. The state's proposal for a new agreement is entirely unacceptable as it results in significant losses for hospitals across the state while generating a windfall for the state of nearly $60 million more than under the existing agreement. And again, while the state's proposal would provide a similar amount of tax revenue generated by them back to hospitals, the state is taking a larger share of the federal matching dollars. And be certain, for those hospitals who are losing money, the state is effectively increasing the tax on them. Hospitals continue to struggle financially as we come out of the pandemic. We all know that. We're seeing higher labor costs, having to bring in nurses and other staff to care for patients and meet the demand in our community. Cutting payments to hospitals will harm patients, all patients, and their ability to get the care they need when and where they need it. The state is shifting the cost of Medicaid services to the hospitals rather than using the federal matching funds for this program. And it will force hospitals to have to make decisions about the services that they're able to provide. The amendment before you gives the commissioner the sole and absolute discretion to determine how hospital payments are made. This is deeply concerning given the uncertainty that this authority provides year over year, especially when our historic agreements have clearly laid out what hospitals and the state would receive in payments. The amendment also, and we understand that there is some confusion and question about this, but we are very concerned that this potentially could remove the requirement that all Medicaid enhancement tax dollars be used solely for the Medicaid program. We understand that those questions remain, and we will continue to advocate for ensuring that Medicaid dollars are used solely for the Medicaid program. The amendment also seeks to use a portion of the revenues generated by the Met that do not go back to hospitals to fund services for other providers, notably community health centers, community mental health centers, substance use providers, and others. We have no issues with wanting to support those other providers, but doing so by taking money from hospitals will only serve to destabilize the entire healthcare system at a time when we simply cannot afford to do so. There is a path forward. Hospitals have attempted to negotiate in good faith to try to find a win-win solution that would benefit everyone, including the state, the Medicaid program, its beneficiaries, and the hospitals and the patients and communities they serve. We would ask that you oppose this amendment so that we can develop an alternative that builds on the partnership that has existed over this past decade to create a win-win that would result in more federal funding for the state and for hospitals and the patients and communities that they serve.
Scott.
Thank you, Mr. Chairman, Senators of the committee. Thank you for your time. I'm Scott O'Connell. I'm from Bristol. I practice law at Holiday Knight. I have represented the Hospital Association and many of its members for the past 12 years. I was involved, and some of the senators at the table, D'Alessandro and Bradley, helped us reach this agreement in 2018, and we thank them then for helping us get focused on patients and using the monies from the Met to leverage the federal dollars so that we had a safety net in this state. And to be clear, it kept any responsibility off of the state's shoulders. The money from the hospitals, from the Met, get used to unlock the match. And we're going to talk a little bit more about the ways in which the federal government can enhance the match, and that's part of what's baked into this amendment. I'll get to that in a minute. But not one dime of that match has come back to the hospitals in any form ever. And New Hampshire is unique in that respect. We are only getting 91 cents of the monies we are paying. Medicaid services by hospitals are self-funded in this state. Most of other states will take a portion of the matched funds and provide real and meaningful reimbursement that would move New Hampshire from 46th in the state, in the country of the 50 states and DC to something better. There is just no data to support the notion that this is a rich deal. None. We have searched in vain. I have searched in vain. I have access to lots of databases to try and track this down. And at the end of the day, the only data that we were able to find was from the American Hospital Association, which recognizes our movement from about 50 when the litigation started in 2013 to 46 now, which is terrific. But we do have a long way to go to make sure that the funds in the state reach all of the patients in need of Medicaid services. Now, there is a context that is important for the state to understand as you consider this amendment. And as you consider, very sorry, Mr. Chairman.
Hey,
I don't know why that happened.
just keep going.
Keep going, yes. The litigation is relevant from a decade ago because the problems have never been solved. In 2014, as Steve mentioned, 2 Superior Court judges found the Met unconstitutional. It was not broad-based and it was not equal. It laid it just on the hospitals and did not hit revenues of the same services provided by others in the state. Recognizing the significance of having a fully funded Medicaid program, the association, again, with the help of 2 of the senators in this room, said we're going to do the right thing. We'll let the federal batch plus the other 9% be used for everybody else in the state that's providing Medicaid services and not give it to the hospitals. And that has worked pretty well. And what the hospitals agreed to do as part of that significant increase from 50 cents on the dollar to 91 was to agree not to challenge the Met. We've been partners in a very functional, albeit stressed circumstance with not enough funds to go around. What I fear as counsel who was involved in those litigations and ultimately the settlement is that the polarization that results from the real consequences of the amendment will polarize and push us away rather than stay focused on patients and the Medicaid services that they need. One data point that was not mentioned yet here today, and we did not have the benefit of looking at the spreadsheet, so I don't know how it has changed from the last one we saw, but the state is going to get $60 million new dollars because of an enhanced match, because of the directed payment. It matches more than dollar for dollar. It's dollar plus plus a lot. And 10 hospitals in the state of the 26 lose $15 million. Now, that's real money. And at the end of the day, you think there should be some solution if the state is really going to net $60 more million. How can't we figure out a way to get that $15 million being lost by hospitals to zero? And the governor referenced why. We have to follow the federal programs. We cannot deviate. We cannot do what we do in this state all the time and make common sense decisions about getting the money where it's needed. Unfortunately, that is the challenge we have. And in order to fix the problem, so there are some hospitals that will be getting more. The governor's absolutely right about that. But the ones we're focused on are the losers in this prospect. And we did go back to the state, and we've had very collegial discussions with the Attorney General and his assistants, as well as Henry Littman, who is truly doing marvelous work as Medicaid director. He works tirelessly, and he's looking for a solution always. But at the end of the day, we said even at 100% match, given the directed payments and how that swings from positive to negative for so many hospitals, we just can't do it. We have to use a different mix of payment methods. We'll have to keep some dish in the program. We will have to keep some directed payment in the program and get the enhanced match. We'll have to do other type of specialty payments. But the consequence of that, Mr. Chairman and Senators, is that lowers the take that the state is going to get of $60 million. There is a win-win here. At the end of the day, the state can come out with more money. We can get the hospitals, all of the hospitals, not to be negative or close to it, as close as we possibly can. And that, we would suggest, meets the goals that we need to hit here. The state gets what it needs for additional services, of very important services in the community, but the hospitals are not harmed. The Hippocratic Oath says, do no harm. This amendment does harm, and we oppose it, and we hope you join us in opposing it. We can do better. We should do better. Thank you.
Questions from the senators? Senator Birdsall.
Thank you, Mr. Chair. Thank you for taking my question. Is it true that you are only holding the mental health care for 24 hours and then sending them out?
No, that is not correct. When a patient with a mental health crisis comes into the emergency room, we do our best. Our hospitals and their emergency room staff and their teams do everything they can to provide compassionate care to those individuals. If it's an involuntary patient, an involuntary emergency petition is filed, and we seek to find a bed for them. No one is told to leave after 24 hours. That is just simply not the case. We are doing everything we can to make sure we're providing care for those people, but the emergency room is not the appropriate setting for that patient to be getting care. We need to get them to the appropriate place to do that. There's a tremendous amount of work going on. The governor mentioned the Mission Zero program. I serve as co-chair of the Mission Zero Steering Committee with Commissioner Weaver, and there's a tremendous amount of work going on, including partnering with hospitals to try and improve the care for those patients to get them to where they need to be. But no, we do not ask patients to leave after 24 hours.
Senator D'Alessandro.
Thank you, Mr. Chairman. Thank you very much for your testimony. I've got two problems with the amendment. I want you to address both of them. The first is the Terry Morton syndrome that has just developed here. And the Terry Morton syndrome is this one. The Commissioner of the Department of Health and Human Services shall have the sole and absolute direction to determine which payment method or methods are used to make hospital payments subject to this section, the Medicaid reimbursement for inpatient or outpatient hospital services. That's the Terry Morton situation, which was created by this legislature, which was an abomination, ultimate disaster. Terry Morton, good guy, God rest his soul, liked hockey at UNH, but when he ran HHS, the bottom fell out. Number one, I don't understand that. I don't understand that. Second thing, we will do this on an annual basis. Why in God's world would you ever do anything on an annual basis? We want a biennial budget. We rebelled against an annual budget. And yet we're saying here that this will be done on an annual basis. This is a significant piece of legislation. It affects the lives of almost every person in the state of New Hampshire. Every person in the state of New Hampshire. For 7 years, we've had a good situation. Not a lot of complaints. We've had a good situation, worked out through the diligent work of legislators. Senator Bradley and others brought a good thing to the table. So I'm very concerned about the Terry Morton syndrome. Really, really bothers me. I'm extremely concerned about doing it annually. All right? I think that's highly problematic. And the 9% that's being held, that could be $60 million, could be $60 million. Why isn't it going back to the hospitals? Why? They're doing their fair share. We understand that there are other needs. We understand that. We're going to be working on that this week in fiscal. But those are my concerns about this. Why in God's name can't 424 legislators come to a situation where we work out a deal? Work out a deal. The magic of the Bradley methodology. Where has it gone? Where has it gone? We worked out a deal. We had a deal. These two things, I think, take the deal and burn it. Actually destroy it. Why? Why have we chosen, again, vis-a-vis this amendment, to give one person the ability to do everything and to do it on an annual basis? Could you comment on both those? They're real concerns of mine. I've got 2 hospitals in my area, the Catholic Medical Center and Elliott, both providers, both do a lot of public service.
I share your concern, Senator. As I noted in my testimony, giving the commissioner the sole discretion and authority to determine those payments, how they're going to be paid, what's going to be paid, is incredibly troubling. the agreement that we've had has created stability. Hospitals have to put together budgets, they have to plan, they have to be able to ensure that they can meet the needs of their communities. And this would throw that out the window. We would not be able to plan, and it would be subject annually to, you name it, all kinds of things could influence that. And so, again, it's certainly something we are very, very concerned about. Certainly do not support it. It's not what we would agree to. It's not what we would put forward. We share the concern, and we don't think it's appropriate.
One comment to add, right now it's a very collaborative process. We work closely, the hospitals do, with the Medicaid director, and we figure out which program will do the least harm when the payments are made. That's completely absent and stripped away if you read the amendment.
Other question?
Follow up?
Thank you. At this point in time, where do we stand in terms of the negotiation procedure? Are we still talking? Are we still negotiating between it seems that Senator Bradley, you're bringing in the amendment, so you've got to be a player in the game. It's your amendment. You put all this stuff together, and the governor's office. Where's the synergy?
Well, as Scott noted, we've been having very collegial, collaborative conversations over the past several months. And several weeks ago, the state came back and said they have no interest in changing their offer. They came to the table with 91% and a radically different distribution model, a distribution model that isn't necessarily wrong, but doing it so quickly creates huge swings in reimbursement for different hospitals. And we have hospitals that are losing significantly. There's a way to do this if we can have a glide path to what that ultimate solution would look like. So we're ready to sit and talk, and I think we can find a way to make this work, but we just have to get to the right goal. And the goal has to be, we're going to support the state, we're going to support the program, and we're going to try and do everything we can to support the hospitals and minimize any losses that might occur.
Senator Rosenwald.
Thank you, Mr. Chairman. Thank you for being here. I want to follow up on Senator Birdsall's line of questioning. Wasn't the federal court case about not just anybody who is seeking mental health care, but people who were being certified for an involuntary admission? And wasn't the judge's directive that as of, I think, earlier this month, that after 6 hours, those patients no longer belong to the hospital, but they are the patients of the Commissioner of Health and Human Services. And so it's Commissioner Weaver's obligation to get them into an involuntary pay. Am I right on that?
You are correct. So that lawsuit, which we did not initiate, was initiated by the ACLU and several individual plaintiffs' patients, sued the state over the question of the time that it took for them to get a probable cause hearing to determine whether they should be held against their will. That was the only issue that was at stake or at issue in that case. The hospital said, wait a minute, probable cause is incredibly important, and we should be finding for probable cause. But the statute also says patients are to be transported immediately to get the care that they need and deserve. That wasn't happening, and frankly, if we hadn't sought to intervene, that issue never would have been on the table. So the court has said, the state Supreme Court has said, the federal courts have said, that when a patient is certified as a danger to him or herself and others, they are to be transported immediately to the designated receiving facility to receive the care and due process that they need and deserve. That's what the courts have found. We fully support that, and we're working incredibly hard to ensure that that happens. And so as patients come to the emergency room, and they will continue to come to the emergency room, whether there's a wait list or not, and so how can we help support them and make sure that those patients are getting the right care at the right time in the right place? And there are so many other things as part of Mission Zero that are working to prevent people from needing that level of service, from getting to the crisis. But the reality is there is a continuum. Patients will need care in the community, some patients will need higher levels of care, some patients will need inpatient care, and some patients will need care after they experience that crisis and exit the hospital. And those are all things that we're working on together. We're working collaboratively, and I'm proud to say that I think we're making significant progress. And I would just add, it is hospitals that have come together and are offering additional inpatient capacity. We have, hospitals that are adding DRF beds. We have a hospital in the state that's adding a brand new hospital, a behavioral health hospital that will add significant additional capacity. So again, the case was actually settled and resolved last year. And so we continue to look forward to try and find ways to improve the care for patients experiencing a mental health crisis.
Follow up?
Thank you. It's actually a different question. I noticed that the estimated Met revenues were about $40 million higher than planned for what you're going to pay in April or May. I mean, you should be paying them right around.
They were paid on April 15th.
Okay. So net patient service revenues have gone up, but could you talk to us a little bit about what costs have been doing? I mean, I think we've all heard a lot about temporary staffing costs and full-time labor costs. Please talk to us about the relationship between revenues and costs.
I would say, and there are others who run hospitals behind me, and I'm sure they can add even more, but there's no question that we are seeing an increase in the cost of labor. About a year ago, we did a study that showed we'd seen a 133% increase in the cost of contract labor year over year. That is a significant cost that we just simply is not sustainable. And it's not something that hospitals alone are feeling. Other providers across the spectrum. We're seeing increases in pharmaceuticals, in supplies, supply chain shortages, delays are causing an increase. But at the same time, we are seeing revenues increase because we are seeing, high demand for care and services. But as those revenues increase, so have those expenses, and haven't necessarily been able to balance those out. So we continue to see increases in costs that are simply not being covered by the revenues that we're raising.
Thank you.
Additional questions from senators. Senator Bradley.
Thank you. I'm not sure we have your written testimony.
I handed it in here.
Oh, okay.
That was easy.
Okay.
Ask me a hard one.
Seeing no other questions, thank you, gentlemen. All right, for the rest of you out there, I'm going to call you up. And remember, you're not supposed to repeat, okay? That's one of the reasons I brought the Hospital Association up first, okay? Holly, you're next.
Hello and good afternoon. I will try not to repeat, but I am admittedly very nervous. It's the first time for me, but I think it's very important for me to be here to tell the story of my hospital. My name is Holly McCormick, and I am a registered nurse. I'm also the president and chief executive officer at Cottage Hospital. And Cottage Hospital is an independent critical access hospital located in Woodsville. This means we're not part of a larger system. Cottage Hospital was founded in October of 1903, providing care to our community for 120 years. Our hospital service area includes more than 25 towns, and we provide many services to our communities in our hospital and our multi-specialty rural health clinic. These services include emergency care, primary care, inpatient services, surgical services, orthopedics, endocrinology, podiatry, urology, laboratory, and radiological services. In addition, Cottage is the only hospital with a trauma designation in the North Country. Cottage also is the only critical access hospital with a 10-bed geriatric psychiatric distinct part unit in the state. We provided care to residents in that unit from 110 of New Hampshire's 221 towns. Cottage Hospital opposes the current proposal to amend the state's Medicaid Enhancement Tax Disproportionate Share Hospital Payment Agreement. Under this proposal, hospitals will be harmed, and the healthcare system in New Hampshire is already stressed and cracking. The proposed changes would take away $14 million away from the state's hospitals. Cottage Hospital would receive $1.5 million less. Since the pandemic, Cottage has experienced a steady increase in volume. Unfortunately, our expenses continue to outpace the increases in volume and revenue. To remain competitive and recruit and retain competent staff, Cottage Hospital has had to increase staff wages significantly. Our salary budget is 28% higher than it was in 2019, pre-pandemic. And despite these increases, 2016 to 2019, Cottage Hospital spent an average of $800,000 per year on travel staff. From 2020 to 2023, the average spend on travel staff per year was $3 million. This number reflects an increased expense of more than $2.2 million per year. This exponential increase in just one category of expense has been dramatic. Drug costs have also increased by 25.6% from 2019 to 2023, and overall hospital supplies have increased by 42% from 2019 to 2023. These increases would be passed along to the consumer in a traditional business, but in healthcare, we cannot follow that path. We must be here to provide care to all patients in our community, regardless of their ability to pay. There's an erroneous belief that hospitals are a lucrative business. That is simply not true. Cottage Hospital is projecting a negative bottom line for the third consecutive year. If we lose the projected $1.5 million, we'll be forced to evaluate our ability to continue our mission of strengthening our community by providing accessible, quality care. Cottage Hospital has another unique attribute, which is the 10-bed acute geriatric psychiatric care unit. This unit opened on October 1st, 2016. This unit is the only 10-bed distinct part unit dedicated to serving the older population in the state, offered by a critical access hospital. The Ray of Hope, named in 2016 to honor former Executive Counselor Ray Burton, serves our primary service area and the entire state of New Hampshire. We have helped approximately 1,000 patients since the unit opened on October 1st, 2016. And New Hampshire needs these 10 psychiatric beds. Unfortunately, we have had to rely on travel staff to keep this unit open. The contract labor expense has hurt our bottom line. The net contribution of this unit to our bottom line in 2023 was negative $713,707. It will not be easy to continue to support this unit in our current position. With the proposed amendment, it would be impossible. The current proposal would make finding a path forward difficult, if not impossible, and I shudder to think of the implications for our patients and community. Traditional hospital and clinic services, as well as level 4 trauma center and specialized geriatric psychiatric unit, would be lost. We experience patients requiring a higher level of care than we can provide, boarding in our emergency department for 6 to 8 hours at a time, sometimes longer, as we seek to find beds for them. Once a bed is found, the significant issue securing ambulance transfers also occurs. The EMS teams in New Hampshire are also experiencing a crisis. On our inpatients units, we consistently experience barriers to discharge, and since the pandemic, there has been significantly less bed capacity in the New Hampshire and Vermont's nursing homes and assisted living facilities. Inefficient processing of long-term care Medicaid applications is a contributing factor. One patient remained in our facility for over a year as we waited for the application to be processed and sought a bed. The patient did not have an advocate or financial means. It was up to our staff to complete the process. We currently have over $1 million in outstanding patient charges for patients we could not discharge for an extended period of time due to one or more barriers. In addition to patient care, Cottage Hospital also provides over $2 million yearly in community benefits. We support students in our local high schools and provide training opportunities from students from River Valley, Riverbend, Plymouth State University, University of New England, and White Mountain Community College. Cottage Hospital has formed its own licensed nursing assistant training program. We have now graduated more than 30 LNAs and have a 10-student cohort due to start in June. We are one of the largest employers in our community with 317 employees, and the town is facing the loss of another significant employer at the end of this month when Upper Valley Press will be closing their doors. The loss of our hospital or any other in New Hampshire will result in harm. The impact on access to care will be magnified, and patients seeking emergency services, primary care, behavioral health, or any other specialty will experience a detrimental impact. Decreased access leads to prolonged wait times and overall harm. In a time where we strive to impact and improve healthcare equity, we will achieve the opposite. I urge you to oppose the current proposed amendment to MET-DISH and to protect our healthcare system, our hospitals, and the health of our citizens. Thank you.
Questions from the senators? Senator D'Alessandro.
Thank you, Mr. Chairman. Thank you so much for your testimony. Tell us a little bit more about the Burton unit named after Councilor Burton and the loss that you have incurred by maintaining
the Ray of Hope unit is a 10-bed unit for acute geriatric psychiatric needs. So it's not a long-term care facility. It's for somebody experiencing an acute need. So those patients that are in boarding and EDs that are typically older adult. We say 65 and over, but they have to meet what we call a milieu of the unit. That unit opened on October 1st, 2016 and was doing very well. As we went into the pandemic, we hit a couple of very big road bumps. If you remember, the population that was 65 and over were heavily hit. And so it became very difficult to get patients into our unit and out of our unit safely. And so our census dipped a little bit. And during that time, we also experienced a lot of staffing challenges. And the expenses increased when the staffing challenges increased. We lost our provider, which made it so that we would have to use a locum provider to staff the unit, which is very expensive. And we also lost a lot of our nursing staff and our LNAs. So some of the things we have done to rectify that situation, we started our own LNA program. If we couldn't hire them, we were going to grow them, and so we've done as much. And so along with the provider, a registered nurse on our unit completed her APRN program in Geri Psych and is being mentored by another Geri Psych APRN in the area. And so she is now our provider. So as of February, we no longer need the locum provider, but we still have a fair amount of travel nurses as we move through the process on that unit.
One further question.
Follow up?
But the service that you provide is a unique service.
Very unique.
Very unique and very needed.
We are the only critical access hospital. We help patients from all over the state, all over Vermont, and from other states. We prioritize our service area and then outside throughout New Hampshire. So like I said, 110 towns of our 221 have been represented on the Ray of Hope. So it's not unusual for a patient from Nashua to be all the way up in Woodsville or somebody from Manchester to be up in Woodsville. And so patients are referred from emergency departments and from primary care offices, sometimes from home and sometimes from local nursing homes.
Thank you.
Senator Birdsall, you're next.
Thank you, Mr. Chair. Thank you for taking my question. Can you say again how much you said your Cottage Hospital would be losing?
1.5 million from the last spreadsheet that I was privy to.
Okay, because I'm looking at the spreadsheet here and it says 136,000.
Yeah.
That is not what I was shown last at the end of last week.
Okay, thank you.
You're welcome.
Senator Rosenwald.
Thank you, Mr. Chair. So my understanding of the critical access hospitals is that it's half of our state hospitals.
That is correct.
And they're designated that way because of distance apart and travel time. And they're all the hospitals in the North Country and the western part of the state. So it's 13 of our 26 acute care hospitals.
That's correct.
This amendment seems like a big change in state law in that it no longer guarantees that 75% of those critical access hospitals will, of their uncompensated care, will get paid to them. It seems that that's out of here now. Since uncompensated care incentivizes hospitals to treat Medicaid patients, could you talk a little bit about what the effect of moving away from the guarantee of 75% of uncompensated care coverage would mean?
I think it's pretty cut and dry. When you're a hospital, you don't turn anyone away. You don't ask for the insurance card when they're registering your emergency department. We have EMTALA laws, and we treat and we stabilize everyone, and we provide care to everyone that presents at our doors. And so that's what makes us different from traditional businesses when you're looking at, upside down. If our expenses are at 42%, if I were running a Target, I could increase my prices by that much. If I were running a restaurant, I would increase my prices. But if I'm running a hospital, I can't increase my rates by 42%. Thank you.
Additional questions from the senators? Thank you very much.
Thank you.
Next on the list is Cheshire Medical Center. We've got Joe and Matt. And for those of you that are experienced, remember we can read, so if it's typed, pass it in and just speak to the high points.
Good afternoon, Senators. Really appreciate the opportunity to speak before you. Is it okay if I go first?
Yes, of course. For the record, Matthew Hood, Vice President of Government Relations for the Dartmouth Health System.
And as I was getting to, Dr. Joe Paris, the somewhat newly employed CEO of Cheshire Medical Center as of August of last year. And I really want to thank you for the opportunity today to speak with you. Since this is the first time I've spoken to you all, just a brief introduction. I'm an internal medicine doc. I've provided inpatient, outpatient care management, leadership. I've been a CMO, a CEO, and most recently a chair of the American Hospital Association's Rural Health Services Committee, where I help to advise the AHA on rural healthcare delivery systems and issues and what they can, how we should be speaking with our legislators on a national level. Born and raised in Dunstable, Mass., proud Bishop Girton graduate, go Cardinals. Family camp up in the Lakes region for my entire life. Proud husband of a longtime New Hampshire school nurse and proud dad of 2 Hanover High grads. I've been part of Dartmouth for 23 years and have spent my entire career caring for patients in both New Hampshire and Vermont. As I mentioned, I joined Cheshire as the president and CEO in August, and I'm really proud to lead a hospital that punches well above its weight class, so to speak, for a small rural hospital in southwestern New Hampshire. Of note, there are no community health centers nor FQHCs in Keene. We serve a county of about 100,000 plus, and Keene itself is about 23,000 citizens. I'm going to speak less about the proposal and more about the challenges of running a hospital and delivering health care in a resource-poor environment. Every year it gets harder to meet the medical needs of our community. Reimbursement for the care that we provide does not keep pace with inflationary pressures that we see in supply chain, the rapidly changing labor market with associated wage pressures, and especially in Cheshire County, which I believe is the second oldest county in the state, an aging population that has more intensive medical and surgical needs. We have the only ICU beds in our region. They remain full, and they remain a struggle to staff. At Cheshire Medical Center, it is becoming increasingly difficult to maintain the clinical services that Cheshire County needs, as we've faced immense financial pressures with significant financial losses over the last few years. We've had to reduce services. We've laid off staff, and access to our providers, especially our medical and surgical specialists, have suffered. We count every paperclip at Cheshire, and despite revenues projected to increase by about 7% for fiscal year 25, our expenses are expected to rise 11+%. In this context, we may also lose eligibility for the federal 340B program, which puts about $6 million on our bottom line. I want to share what expense reduction looks like in response to what revenue reimbursement cuts look like. We risk the loss of staff, crumbling infrastructure, and reduced access to clinical services. I can't think of a world where further reductions in revenue, and in Cheshire's case, it's about a $1.7 million swing on what we would, on the losses that we would get in the current DISH methodology to what the new state's proposal is. So those are real dollars, especially for a small community hospital. If we don't provide raises for our staff, again, in response to this rapidly shifting market, we run the risk of losing them, and our reliance on extraordinarily expensive contracted labor will increase. We are already spending about $2 million a month in contracted labor, or otherwise known as traveling workforce, nurses, docs, technical positions throughout the hospital. Our operating rooms are 50 years old. We need to make major investments in our infrastructure because the rest of the hospital is also 50 years old. We will struggle to recruit physicians, surgeons to our community without a modernization of our facilities. And we have just not been in a financial position to do that. Despite being a part of Dartmouth Health, we are expected to stand on our own bottom line. Well, I'd love to envision a world where I just get a check at the end of the year from DH to cover losses. That's just not how we operate. Fundamentally, reductions in our expense structure translates into a reduction in services. The core services that are critical to our communities generally have negative contribution margins. That's just the nature of the business. We're a mission-driven nonprofit medical center, so we are committed to providing robust family medicine, pediatrics, obstetrics, and behavioral health. As a quick side note, and maybe avoiding a question that may come, we have at least a couple behavioral health boarders in our ED this morning, one of which has been there for 10 days. So we are still providing the care that our community members need. Reimbursement for these services in an environment where just under 70% of our patients are on Medicare or Medicaid simply do not allow us to absorb further losses in operating or non-operating revenue without reducing the services or access to care that our community needs. Cheshire Medical Center will suffer mightily with the state's proposal to change the current MedDish methodology. I've already mentioned the losses we'll face in the new proposal. In response to our budget stresses already, we are slowing down hiring, we're delaying some overdue capital investments, and trying to reduce traveler expenses to close the gap in our upcoming fiscal year budget. We're trying to mitigate these effects on patient access, but there's only so much daylight and wiggle room to do so. Reducing revenue by another $1.7 million simply amplifies those stressors. And as I said, despite Cheshire being part of Dartmouth Health, we don't have the system-wide bench depth in providers, nurses, and other staff to ensure that we provide ongoing access for our medical and surgical services. I'll close by saying I just want to be clear that Cheshire Medical Center is not trying, I'm testifying not because we're trying to win anything here, we're trying to lose a little less with any revision of the MedDish methodology. I thank you all for the opportunity to testify today. As I've said, I've spent my entire career caring for patients in New Hampshire and will close my career doing the same. I've spent a lot of time studying healthcare delivery systems, especially in rural environments. And to echo Holly McCormick, we are in a very fragile state right now with healthcare delivery in New Hampshire, and would hate to see us deteriorate further. So with that, I'll end. And again, thank you very much.
Yeah.
Thanks, Mr. Chair. I will be very brief. Excuse me. Because I think the CEOs have provided a thorough description of the challenges that they face in the environment where revenues are more constrained. What I would like to do, however, is give a system perspective, a Dartmouth Health System perspective, and we have Cheshire Medical Center as members, Mary Hitchcock Memorial Hospital, Alice Peck Day, New London Hospital, etc. I also, before doing that though, I feel like I need to call out what is evidently clear. You have a spreadsheet in front of you that I'm not familiar with, I've not seen. The spreadsheet data that you're hearing from the hospital CEOs, and you will hear from me, stem from the 91% proposal that was being discussed with between the Hospital Association and the state previously. So if there's been an evolution, I'm just unaware of what that evolution is, but just understand that you have one formulation. We're working from a different formulation. So I just wanted to make that clear as we go forward. So for the system perspective, which is to say, what's the aggregate losses among our members? So we're already losing over $5 million compared to what the Met paid, that we pay in tax. So under the proposal that we have seen, we would lose an additional $5.5 million as a system. Those types of differences just can't be seamlessly addressed. I think Dr. Paris has spoken to the challenges of that. He talked about the challenges in finding savings in the 25 budget process. What he didn't address is that Dartmouth Health System members just went through a $100 million performance improvement plan to try to get us out of the red and into a more positive position. There's just not much more to squeeze or efficiencies to find in this with that magnitude of reduction in the DSH reimbursement. Dr. Paris also talked about the potential benefits of being a member of a larger system, which is that we would want to help our members expand their services because we understand that there's a constraint and need in the community. Never mind Dartmouth Health being able to support our members' expansions, we would struggle to try to help them close holes that were created as a result of this proposal, holes that just don't need to be made. So I want to be clear about that. Anticipating Senator Bertzel's question, I just wanted to speak to some of the things that Dartmouth Health members do in their community. We operate 2 doorways for substance use disorder treatment, one in Keene and one in Lebanon. We partner with local community mental health centers. In fact, at this moment, we have seconded the administrative director of our psychiatry department to head the community mental health center in our region because they're doing a CEO search. We are adding 5 designated receiving bed facilities to Dartmouth, to Mary Hitchcock Memorial Hospital. We are increasing the number of voluntary beds. We provide the clinical services at New Hampshire Hospital, and if the item on Governor and Council goes through tomorrow, Hampstead Hospital will be added to that. So we are engaged in the space of taking care of the psychiatric needs of our citizenry. One other piece that I would just say, community health needs assessment, every hospital needs to do them. Dartmouth Health is engaged with each of its members in meeting the needs of those communities. And I don't know, I think Steve handed out what the net hospital gains are. It's hundreds of millions of dollars over time to go into those, and we would have to do less of those community needs. And we want to serve the needs of our communities and our patients. Thank you. I said I'd be brief. I apologize. Done.
Questions from senators? Senator Ennis.
Good afternoon. Thanks for being here. I need a little help. I have 2 spreadsheets in front of me. One is from the governor, and it shows a net gain for Dartmouth Health of $793,000 if this is implemented. Now, the Cheshire Medical Center does take a hit, but Dartmouth Health as a whole comes out all right. Then I have another spreadsheet that shows the state 91% model. And on this one, just picking on Mary Hitchcock, it shows a $2.5 million reduction. Which is right? What am I looking at?
Well, I can't answer the question with respect to the sheet that was handed out before the hearing because I haven't seen that.
There it is. I just want to be sure we're working from the right numbers, and they're different numbers that I'm hearing in testimony versus what we're looking at up here on our spreadsheet.
Thank you, and thank you, Senator, for the question because it goes precisely to the point that I tried to preface my testimony with, which was you're looking at 2 different pieces of you're looking at 2 different spreadsheets. We can.
Well, I like one better than the other, as you might imagine.
Okay.
All right.
So
we're not sure.
I would too if I understood
that. For someone else later, so we'll try to get to it then.
Questions
on this one, if I might, though, it doesn't look too bad for the system as a whole, though your hospital is disproportionately affected.
Okay. Thank you. Questions from senators? Seeing none, thank you very much. We got North Country Healthcare next. John?
Good afternoon. Thank you. You've asked for no redundancy, so I promise mine will be the briefest of the addresses today.
Well, I don't know. Greg is after you, so.
Well, it sounds like a challenge.
There you go.
Good afternoon. My name is Tom Mee. I'm a licensed registered nurse and also the CEO of North Country Healthcare in Coos County. North Country Healthcare operates 3 critical access hospitals in Coos County, Weeks Medical Center in Lancaster, Androscoggin Valley Hospital in Berlin, with the only OB program in all of Coos County. and Upper Connecticut Valley Hospital in Colebrook, which is the smallest and northernmost hospital in New Hampshire. Each of our hospitals is fewer than 25 beds. I do want to respond to the governor's opening comments when he attempted to paint a picture of us versus them. There's hospitals on this side and SUD programs and FQHCs and mental health centers. In Coos County, there's no us versus them. It's just us. The FQHC failed in Colebrook and NCH absorbed it, and now we invest in primary care in Colebrook. The FQHC that is embedded in the hospital at AVH in Berlin is subsidized every year by NCH, and these sub-programs are all owned and operated by NCH. So it's just us as it relates to Coos County. There is no them. The New Hampshire Medicaid Enhancement Tax is a critical component of funding for the state's Medicaid program. It's returned to the only 3 rural hospitals in Coos County in the form of disproportionate share hospital payments holds particular significance due to several reasons. Number 1, financial stability for rural hospitals. Coos County, like many rural areas, often faces economic challenges, including a lower population density and higher rates of underinsured or uninsured individuals. Rural hospitals in such areas operate on razor-thin margins and may struggle to stay afloat without sufficient funding. Hospital payments, currently in a form of dish payments, funded in part by the Met, provide essential financial support for these hospitals, ensuring they can continue to serve their communities. Payment to hospitals as part of this program helps ensure that health care is available to North Country residents. Even one hospital closure in the North Country would result in travel upwards of an hour for area residents to reach the nearest hospital. Number 2, preserving access to health care. The NCH hospitals are often the only primary or only health care providers in their communities. Essential services such as primary care, mental health treatment, and birthing services are provided by NCH hospitals at a cost far greater than reimbursement for the number of the current payers. Without them, residents would have to travel long distances to receive medical care, leading to delays in treatment and potentially worse health outcomes. In fiscal year 20 alone, North Country Healthcare Hospitals provided more than $14.5 million in subsidized services, community benefits, public programs, and financial assistance. By directing Met revenue to rural hospitals in Coos County, policymakers help maintain essential health care services and ensure residents have access to timely and quality care close to home. Number 3, addressing health care disparities. The rural population of Coos County faces unique health care challenges, including higher rates of chronic disease, limited access to specialists, and disparities in health outcomes. This is validated year after year in a community health needs assessment. Coos County residents, the majority of NCH patients, are the sickest and oldest in the state of New Hampshire. Many of these patients are either insured by Medicaid or lack health care insurance entirely. Many of the county's residents require more services than their counterparts in healthier areas of New Hampshire, services from which the hospital does not see adequate reimbursement to cover the cost of issuing such critical care. By targeting Met funds to rural hospitals through dish payments, policymakers can help address these disparities by ensuring that healthcare resources are allocated where they are most needed. And number 4, supporting the local economy. The NCH hospitals are not just healthcare providers, they're also significant employers and economic engines for the communities. In each one of our communities, we are the largest employer. They create jobs, purchase goods and services locally, and contribute to the overall economic well-being of the region. By supporting rural hospitals through Met-funded dish payments, policymakers can help sustain these economic benefits, bolstering the resilience of Coos County and its residents. For the benefit of New Hampshire residents and for healthcare's viability, we implore a vote against the amendment to the state's proposal regarding the future of the Met Hospital Payment Program. Thank you.
Questions from the senators? Seeing none, thank you very much.
Thank you.
Elliott Hospital, Greg.
Good afternoon. Thank you, Mr. Chair, for the opportunity to speak to the committee. I'm Dr. Greg Baxter. I'm an emergency medicine doctor by background, and I have a unique perspective into the psychiatric care in the state. Should you all have a couple of hours, I'm happy to talk to you about it. Not today. I'm president and CEO of Elliott Health System for the last 6 years and have the honor and privilege to serve as the chair of the New Hampshire Hospital Association. I'd open my comments by saying that the sense that the hospitals are not involved in psychiatric care is a bit unidentifiable for me. Elliott has had 39 inpatient beds for as long as I've been in town, which has been over 20 years. We added 4 more beds 2 years ago. That's a combination of voluntary and involuntary beds in the center of the state where the population resides. And we've labored and efforted with our partners, Southern New Hampshire Health in Nashua, to bring a joint venture to life for 140 plus beds in Londonderry with groundbreaking in July. So I think we're in the game. When I think about the proposals in front of you, and I don't want to review the spreadsheet with 10 seconds to spare to look at the spreadsheet math, but I would say from the Elliott perspective, it's likely to show that the Elliott's historical deficit position is materially improved in these models. So you wonder why I'd be here speaking pride and perspective in opposition to this. I don't look at things on a one-year basis. And I'll now switch to my more significant point. Senator D'Alessandro brought it up exactly. The inability to predict year over year with a year-over-year analysis and plan developed by a single human, the commissioner, is very disconcerting. It's a very complex process, probably benefiting from multiple pieces of input. So that's the first thing that creates instability and a lack of predictability. Moreover, the sense that we have that what was called the Medicaid lockbox or dedicating these funds to Medicaid could be loosened or eliminated really challenges the ability for us to provide health care across the citizens of New Hampshire, specifically the Medicaid population. So with that, I hope that you have the opportunity to take the information you've heard today and maybe we can come up with a better plan. Maybe there's an opportunity to think and bring things back. It would appear to me, if I was to be so bold, that perhaps the spreadsheet you have has shown some movement since the last one that was produced. That could be an encouraging sign. Thank you.
Questions from the senators? Seeing none, thank you very much. Henry has stepped out.
Of course.
Of course.
Okay, that leaves me in kind of an interesting place. All right. Is there anyone else that signed up after I got the first sheet, or is there anybody else that wants to testify now that? Okay. I'm going to, huh?
He'd love to stop looking at it.
I am going to recess this hearing for a period of time, and we'll reconvene it in a couple of minutes. So we'll be in recess for at least 5 minutes. That'll give people a chance to go to the bathroom or whatever else you want to do.
It's for me, Senator.
Okay. All right, we'll call the committee out of recess, and
Good afternoon, and thank you for allowing me to have cleanup. I feel I can do some of that for you. For the record, Henry Lipton, the state's Medicaid director. I'd like to start that part of why we're here today is because there's been significant changes in the underlying law that drives how this program has worked. After 18, the definition of uncompensated care changed federally. What can be counted as uncompensated care has changed. The U.S. Congress and President signed into law reduction in DSH allocations per state. New Hampshire is one of the hardest hit states expected in terms of the DSH reductions. This past year, they passed a one-year moratorium on the reduction. The concept of a lockbox, I think there may be some misunderstanding that what's in the current legislation. At one point, there was discussion about not having the lockbox, meaning that all the money that comes in from Met stays into Medicaid. The way that this amendment is drafted, it does, if you look at the intro language in Section 1 and Section 9 together. You'll notice if you go back to the original bill that statute, that 167 begins a lot the same. And I had a conversation prior to just point that out. So I'm not sure that lockbox is really an open issue now. So then why are you seeing the big differences between the spreadsheets? I think that we had provided both the governor's office and to the hospitals to the Hospital Association on May 9th, using the parameters of the 91% and the 5.4% tax. Our original model from the state included only just under $37 million in DSH. Our new model, still, again, following the 91% to 5.4%, has almost $111 million. The hospitals had proposed almost $147 million. In terms of the coming off the DSH. Now, DSH has a federal match of 50%, meaning that for every dollar we put in, we get a dollar back. It's the least efficient way for the state to draw down its federal match. When we use either payment rates or directed payments, we draw the match based on the eligibility of the person. So in Granted Advantage, we would draw down 90%, and in the CHIP program, we'd draw 65%. Another piece of information is that in measuring what is the extra that would come from the state, it's $25 million. I think the Hospital Association, when they were talking about the $25 million and then matching that at a higher rate to come up with the $60 million. The other thing in terms of Cottage Hospital as one example, again, looking at how the smoothing worked, we added 3 critical access hospitals. We added a supplemental payment, which is another form of payment, somewhat like DSH, still at 50%. We added $1.5 million to each of those hospitals, and that's why you see that discrepancy there. So in terms of trying to optimize the available funding to smooth it out as much as possible, that's what's going on there. So some of the things that are in the existing statute that probably aren't as viable as they used to be, like when we talk about uncompensated care, there's a narrowing definition in terms of what we could pay critical access hospitals, as an example. Right now, we're seeing a lot of changes, so the concept of having to be able to look at this annually, we're seeing that with the change in pace of what's going on, particularly if DISH is brought down over a period of time, it will require us to change our strategy. But the basic methods of addressing the 91% back to the hospitals is to use a combination of rates. So in our proposal, for example, let's see, let's get my paper here. I'll just do it off my head here. So for example, our inpatient base rate for an inpatient admission is a little over $3,000. What we're proposing in rates is to move that up to between $7,000 and $7,700. So that's when we talk about what we're moving into rates. And then directed payments, I think the hospitals, based on what they heard at their national level, wanted us to go a little slower there. Our more recent May 9th proposal goes slower there. We brought that down from a little over 95 million to about 82 million. And so I think that what we're trying to do is find the right mix here. And the reason I think the commissioner needs more discretion than under current law is because of all these changes that are happening and rules and regulations with respect to what qualifies for match. We can't get in a position where I think we always can consult, and I think the intention is to always consult with the hospitals. But at the end of the day, what we don't want to do is end up with a expected expenditure with a federal match and not achieve it. So let me stop there. I think that's some high-level things that I heard that hopefully I cleared up a little bit.
Questions? Senator Rosenwald.
I have several if I could. Thank you. First, as I look at the governor's spreadsheet, I'm wondering where state fiscal year 24 is.
Yeah, so 2025 is when the new model comes in place. The model that's being worked under current law is we're right in the middle of doing that, but the uncompensated care that we pay out each year is based on 2 years prior. So the numbers, if we use those numbers for 24, we'd be using 22 uncompensated care numbers. We could certainly calculate that, but we're in the process of validating those numbers with the hospitals to make the payment by the end of May. But that is possible to produce.
Because it's confusing.
I think it's just because the 23 is where we have good, clean claims information, and we've been open with sharing that with the hospitals as well. When you look at 24, it's still in a draft phase. That's why.
That's all right.
Follow up?
Thank you. So I get that. Oh my God. I'm sorry.
Happens.
I understand why directed payments are maybe a good idea, and they will certainly bring more money in to the state because we'll get the match based on who the Medicaid person is versus just the 50% match for DISH. But how would the department design directed payments? In other words, what would you be incentivizing and disincentivizing hospitals to do with the directed payments that you'd be designing?
Sure. We have some history. We converted the critical access hospitals to directed payments already under the current structure. And basically, we have to work with the hospitals in designing those. And again, here's another area where CMS is asking states to sort of step up their game. But basically, we try to tie it to metrics that are in the national sphere of common metrics that hospitals need to improve upon. And so we have to make the payment sort of on a value-based basis. There has to be a certain level of achievement of outcomes to make the payment, because directed payments can only pay for Medicaid patients. They don't pay for all of them. And so with respect to the directed payments, we work with the hospitals. We then develop a plan that we have to submit to CMS, and it takes a good amount of time of back and forth with CMS to get something approved. And we have, been successful in getting them all approved. What I think we're trying to do here, actually the hospital's original proposal had more directed payments than what we're having here. Again, I think that was to try to create a win-win, but I think that it requires a lot of collaboration because we need to understand what they can do, because the intent is not to not pay them the money. The intent is to create a program that that provides an opportunity to earn the payment by producing a metric. Right now, we've sort of started at a low end in terms of paying for sort of reporting, and then about 2% at risk for sort of performance. I think the maximum that they're looking to have at risk currently federally is like 4% in terms of the metrics that have to be achieved. But things like that are common to Medicare, CMS seems to be interested in trying to get comparative data where they can, comparing Medicare results with Medicaid results.
Could I follow up?
Follow up?
Thank you very much. So, under the current law that's expiring, we put the state's 9% share into Medicaid provider payments. Although the plain language of the current law and this amendment really doesn't require us to do that. If you look at page 1, line 25, 24 and 25, it says Medicaid services and programs administered by the Department of Health and Human Services. The department has plenty of programs that aren't Medicaid and don't draw a match. That may not be your intention, but that's how it's written. I guess my question is, so under the current law, with the 9% state share going to Medicaid provider payments, the hospitals would naturally be the biggest beneficiaries because they've got the inpatient, they've got the outpatient, they've got most of the doctors in the state. But this amendment directs that 9% away from hospitals to important, but also programs that just got, on average, an 11% rate increase. So I guess my question is, would you agree with me that the hospitals are kind of getting a double whack by not having gotten a rate increase and then having the state's 9% share directed away from them?
Respectfully, I do disagree. If you read the first part of paragraph 9, in terms of going into provider payments, that a large part of the provider payments come in through the managed care program, and that the hospitals are going to be fully funded in that respect. Also that within the Medicaid program, just to give you a sense of some of the breakthrough therapies, when I started just a little over 6 years ago as a Medicaid director, we had 18% of our budget going towards pharmacy. It's now over 30%. So part of, I think the interest of the state is also experiencing increased costs. We have identified 66 therapies that cost over $100,000 each that potentially could come and affect us in the next year or so. We know about 30-something for sure, but I think that's part of what's going on in the state's expense area. But with respect to the 9%, I think it's to make sure that those areas are prioritized in terms of funding. And it doesn't make sense for us to use the dollars in a program that earns less than what we could earn. And so I think that while you could, if I read it your way, I could see where you could say it could go somewhere else. But I think from a management of our budget, it doesn't make any sense to do so, because getting 50% or more on something requires us to put it in the Medicaid program. And I do feel that together this intent and the language does, hold up to putting all the money into the Medicaid fund, as we're calling it now.
Follow-up?
But do you disagree that the 9% is basically directed away from hospitals to community mental health centers, federally qualified health centers, and substance use disorder providers?
I don't, because I feel that the overall MET that's coming to the department is enough to cover more than cover what the hospitals will have, including after we provide a significant rate increase if this were to pass.
Could I ask one more question?
You can
Thank
have
you.
one more.
I was hoping someone from the Bureau of Behavioral Health and Division of Bureau of Behavioral Health would be here, but our community mental health center and the whole system is experiencing funding needs, I guess is the way I'll put it. But are you aware that for 2 years, we've been told by the department that they can't give us accurate caseloads on the community mental health centers? So we really have no idea what we're getting for the millions that we're putting into it? And it's sort of a rhetorical question because you're not
I can.
the Division of Behavioral Health, but they're not here.
So with respect to a substantial amount of the funding, I can speak to that we do have to set, so behavioral health deals with both Medicaid and non-Medicaid. With respect to the Medicaid component, we do have to have claims information. Our actuaries do have to have claims information. We do need it to set the capitation rates for the mental health centers. I feel that for Medicaid, I can produce what's needed because I have to do that to validate the premiums that we pay to them, the MCOs.
Thank you.
And D'Alessandro, you reached for that button several times.
Thank you. Thank you. And Henry, thank you so much for your help. But let me connect with what Senator Rosenthal said about the 9%. Again, this is from the proposal that's before us. The proposal contains the same language as the current agreement, but adds the following. From the amount dedicated to Medicare, an amount of at least 9% of the MET collected in the prior state fiscal year shall be used to support Medicaid services and programs administered by the department, with first priority to funding Medicaid service provider payments to community mental health centers, federally qualified health centers, substance use disorder providers, and other Medicaid services. Now, I consider that language mandatory for that 9%. That pulls it away from the hospitals and puts it in another direction, does it not?
I think if there was not, if the pie was not large enough from the amount that came in, like for example, if the Met was, instead of nearly $320 million, came in at 200 and something million dollars, I think I would agree with you. But with respect to kind of where it is and where it's trended, I don't see it as being an issue. I think that we do need to, those federally qualified health centers, driving things in, hospitals provide primary care, but FQHCs are a very important part of the access system for Medicaid individuals. I don't feel that is just, I think, calling out the fact that those things need to be funded as well, which is why 100% of the MET going to the hospitals would potentially put a squeeze on the other parts of the system.
Well, just if I could
Follow up?
But from my perspective, it appears that that's the case. Now, again, I didn't write this. I'm just reading it and trying to gather from it the intent of the language. And it tells me that a significant amount of money, between $35 and $60 billion, will be going in another direction.
Well, today we fund over $100 million with mental health centers as an example.
Additional questions? Senator Pearl?
Thank you. All right, Henry. I've been sitting here for an hour and a half trying to figure out what everybody is talking about.
God bless you.
So, this spreadsheet that the governor gave us, is this accurate?
Yes. It reflects a model that we gave the Hospital Association on May 9th. It's faithful to the 5.4% and the 91%. What it does do differently than the original proposal when we went to 91 and 5.4% met tax is that we changed the mix of payments. We moved towards where the Hospital Association was going, which is more in DISH. We went from almost 37 million in DISH to 110. The reason why that's helpful to the hospital is because the other forms of payment can only be paid for Medicaid patients. The DISH program can pay for both people who don't have insurance and Medicaid. So it for those hospitals that have a lower mix of Medicaid but a higher of uninsured, it helps balance it out. That's why I think we agreed with the hospitals that to make it less severe. I know they would like it to be even less than the impact that it has, but it produces 12 million more than in 23, and the 12 million plus that goes is mostly to the critical access hospitals. And we did also use another form of payment, the supplemental payment, to particularly on a few of the critical access hospitals. So I don't think that it's the same information or a different version of the model that they're looking at, but this is something that I've cleared with the governor's cleared in terms of being the model that we could use if there was an agreement.
One follow-up. So, looking at, I'm going to use Concord Hospital, their group. Lakes Region Hospital looks like they're taking a really hard hit here. They're about 35% hit, or maybe more here on my quick math. That is because of the type of patients that they have in their hospital?
It could be the type and amount, I think.
Because Franklin is essentially getting the same amount back, but it's a much higher percentage of what they had. So I'm just trying to get my head around how that occurs.
Yes. So it could be can be a combination of the amount of individuals and the mix.
Okay. All right. I won't tell you I understand it, but I think I got a little better handle on what I'm reading. Thank you.
All right, just a second. You can provide the spreadsheet to the Hospital Association,
Yes.
and they can distribute it out to everybody else. I would appreciate that.
Absolutely.
Senator Rosenwald, you got a question?
I was listening to you say, well, on May 9th, we recalculated how we would distribute the 91% to the hospitals. And then as I read, the commissioner in sole and absolute discretion can do this every year. It seems like there's a lack of predictability for hospitals. If like on May 8th, it looked like one thing, and on May 9th, it looked different.
So I think in terms of listening, we heard what the hospital said and we ran probably 5 different models and tried to come up with the best one that we could. And we gave it to the hospitals, and then we met with Paula Minahan to walk through the model with her to help her understand it. And certainly we gave them exactly what we're using. That being said, we are in a period where with the definitions changing, and particularly with the changes in what amount of the DISH allocation that the state's going to get, that could go down markedly and force us to have to make changes. And I think that right now we're on an every year basis. It's supposed to go from like 200-something million to eventually our allotment going to around 39 million. And so we don't know whether that's going to come in, the Congress is going to continue to do that, and then in 1 year decide, well, we've done as much as we're going to do in terms of holding back and take a big chunk, or whether they would just push it out a number of years. But there's only a one-year hiatus now on the books with respect to a reduction for the state. And so we do have to, I think the hospitals would agree that when the DSH allotment goes down, we're going to have to make changes, and those changes could be annually. And I think the thing that we want to do is, I think the program, when you pay directed payments and rates, it encourages you to serve more Medicaid patients, which, as a Medicaid director, I think is a positive of the model, that the more Medicaid patients you see, the better that you're going to be compensated. So I think that there are some good incentives built in here based on the direction that the feds are going to fund the program.
Could we ask the hospitals to come back and comment on
Well,
the spreadsheet?
before we do that,
Yeah.
we will continue on. Senator Bradley, you had a question?
Yeah, and maybe Senator Rosenwald gets at it, but I'm just trying to understand the two spreadsheets. One that I was given a couple of days ago by the hospitals, and the one that I'm sure you developed. So if I understand it correctly, the total difference between the net benefit to the hospitals, and obviously some win and some lose, in your spreadsheet was $12 million, and in the hospitals, it's $15 million, both at 91%. So that's my first question. Is that correct?
They both pay out, all the models at the state at 91% pay out the $290 roughly million. And it's just a matter of how it gets distributed among the hospitals. So trying to, when I say smooth it out, to make it.
So that's where the difference comes
That's
in
one
the fact
difference.
that you move up the distribution to the hospitals under a DSH formula as opposed to a directed payment, going from, I think you said, about 40 million to a little bit over 100 million.
Correct.
And that was what is reflected in, well, it's my amendment. Is that correct? So it.
Yes.
And that mitigates the impact on the hospitals.
It spreads out so that there's not, the red and black is narrower among the hospitals. It's the same dollars, but tried to spread that out in a more, I guess, fairer way based on how the system is currently available to us.
And Henry, do the hospitals have the calculations behind that spreadsheet?
Yes, and as I said, we gave Paula and Steve the model, and then met with them. I think certainly spending some more time with them. They didn't have a lot of time with us, but we did have one meeting where we walked through the formulas. We've been open. I think we've had a nice interaction about sharing information between us. That's not an issue, and we certainly are willing to, you could extract what is on the spreadsheet you have in front of you from our model.
And under the amendment, the net benefit to the state would be?
So 25, we calculate 25 million in general funds and then matched.
That's where the 50 comes in. And what do the hospitals estimate under their scenario the net benefit is? 30 and matched to 60?
I think that's what I surmise, that they might also see 25, but using a different matching percentage.
All right, but that comes in the shaving of the DSH, right?
Right.
Okay, all right.
Okay.
That's it for now. Thank you.
Cindy, before we bring the people back, okay?
Go ahead.
We're getting to the point where we're trying to talk about the merits of the bill. So I would be more comfortable in closing the public hearing, going to an executive session, and then continuing the conversation on this until, we're not going to vote on it today that I know of, because I don't think we're anywhere near ready, but that would allow me to get into, I think, the proper mode so that the senators can express their opinions. Would that be agreeable with you?
I was hoping to ask Henry a question.
Absolutely.
Thank you. So the pie will get bigger through directed payments because the match is bigger.
Right.
And it's either $62 million bigger or it's $72 million bigger. But in this proposal that is before us, the hospitals get $12 million and the state gets either 50 or 60 $1 million. Am I right on those numbers?
It's the 25 million in general funds. We
Right,
calc-
but I'm
yeah,
including
yeah.
the total.
Yeah, yes, I think that, but also true, and just similar to the hospitals, and as I point out, you know, our very expensive therapies that are coming available to people. I can give you one example, Zolgensma, which is used to treat children who have a form of dystrophy, and we've had 2 of these payouts already. Just the biologic itself for those children were over $2.4 million just for the therapy. That's on the extreme end, but there are more than one now of therapies that are in the 7-figure area, and there are more and more therapies coming available that are in the 6-figure area. So I think, you know, in terms of, you know, funding for the program, I think the fact that there is some additional available, given that the definitions that the 18 legislation was built on was based on a more favorable position than ultimately ended up in federal law, that the hospitals have had the benefit of a definition of uncompensated care that's a New Hampshire definition, which is more generous than the federal definition. And I know they will argue, on the other hand, that when you look at how much they pay in net versus how much they get back in total payments, that it's less. But that the reality is it could even be lesser, and there could be other reasons why that doesn't, you know, stay the case. But you know, I think the bottom line here is that the amount that's included in this bill carries forward the concept of paying 91% out that on the definition that we've in some ways based on the definition we've used historically. And I understand where they're coming from in terms of, you know, it's still less than what they pay in the tax.
Okay.
Mr. Chairman, can I just clarify one point? I don't want to quibble, but the spreadsheet that Mr.
You need to get to a microphone. Let me do this, okay?
This is a quick point, and it's
yeah,
important.
and we're going to hear from you, okay? Because in executive session, we can still ask for input. But I'm going to close the public hearing, and then I'm going to ask for a motion to go into executive session. We have a motion and a second to go into executive session. All those in favor say aye. Aye, okay. We want to hear from you.
Thank you. Again, Steve Onan, President of the Hospital Association. I just want to clarify this issue of the spreadsheets. As Henry noted, we received that latest spreadsheet on Thursday of last week. If I'm mistaken, that spreadsheet said do not distribute. So we did not distribute that spreadsheet. So that is why you have multiple spreadsheets. But I think, Senator Ennis, your comment made all the sense in the world, which is we have 2 spreadsheets. One makes progress, and my comment is there's progress yet to be made. And if we sit down with the goal of trying to solve this together, I think we can find a spreadsheet that we can all agree on. So again, I just wanted to be clear. We did not share that spreadsheet because we were asked not to do so. So please understand that you know, we're happy to share that with our members when told we can do so.
And as far as I'm concerned, we will not be taking action on this bill. So you do have a little less than 7 days to get it done. Okay? Senators, any more comments on this bill? Senator Rosenbaum.
You know, hearing about the expensive drugs, it occurs to me that directing the state's 9% share towards organizations that don't necessarily administer those expensive biologics, maybe the community federally qualified health centers do. I'm not sure how this proposal is going to help with the rising cost of the part of like the medical plan biologics, not prescription drug plans.
what I was trying to get at there is that the fact that the state does a bit better in the general funds component isn't that it's going for a purpose that isn't needed, that it could go towards helping fund some of the increased costs that the program is going to experience with respect to the latest therapies, some of which are administered in hospitals. So, there's funding that, some of that would go to hospitals in the form of payments for services.
Additional discussion from any of the senators? Senator D'Alessandro.
There are a couple of questions that maybe Jeb can address them if we have discussion on the piece of legislation. But the two new funds that are created, the Medicaid Payment Fund and the Disproportionate Share Hospital Fund, where did they come from?
They reflect that the change in what's happening with uncompensated care and such. The Medicaid fund is intended to do the same thing that the uncompensated care fund is, to take in the money and then to make sure that it's available for Medicaid.
Now, what about the lockbox that was present before?
Yeah, I think during the course of discussions, there was some discussion about not having the lockbox. I think in the end, and part of the back and forth of things, that the current legislation's drafted in a way that we feel that the lockbox is honored and is in there. I'm not an attorney by trade, but just in terms of working with attorneys at the department, with the AG's office, we feel it's there.
Okay, thank you.
Further discussion on the bill? Okay, thank you very much. And we are going to move on to the other things on our agenda. The next bill I've got is 1593.
We'll make a motion of ought to pass. All right, I'll wait. Sorry. I'll reintroduce my motion in a second.
Oh, excuse me, 15. We're on hold on 1583.
Correct.
We're on hold on 1593 right now.
You don't want to do 1593?
1593, okay, we need the amendments. Right,
Yeah.
15, that,
So
that
that,
one's
we
on
wait.
hold, right?
Okay, I'm sorry.
I have other amendments for ones that were going to be exempt.
Okay.
Okay.
I mean, you have the list.
No wonder I'm confused, huh?
Yeah. Yeah, you and me both. Being away a week didn't help.
So we're just doing these two? 1647.
Okay, so what amendments do we have? Okay, so then we'll go to 1647.
And I will move on to pass.
1647, we have a motion of ought to pass.
Can I be recognized?
Yes, you can.
So, first of all, I'm not sure if everybody has received the GRS actuarial.
Yes, you do.
I know there was a summary that the LBA did, but I have the background documents. Is it in the book?
You
Okay.
can bet it is.
First one is
In case you want.
the 10-year version. And this one is the 15-year version. And then, hang on for a minute and I'll... Okay, all right. They have the LBA summary. No question. All right.
these the same thing?
So,
Oh, no, okay.
probably the best sheet to look at is in the notebook. This is probably the best sheet to look at, the summary of.
No, I think it's the second version.
This sheet right here.
Okay, is that in our book?
It's in the book. Because there's nobody at preparing us better than Deb Martone.
That's for
So,
sure.
kudos to Deb. So, the first on the sheet is the House pass version. The unfunded liability is $53.6 million. It goes to a 2.5% multiplier at 10 years for Tier B. Tier B being people that were already hired but were not vested in 2011, and Tier C. Tier C are people that were hired after the changes in 2011. That cost is $53 million. Trying to get the cost down, I brought forward 2 amendments, maybe a month ago, got them to Marty, he got them to our actuaries, which is what I just handed out. The second proposal, which is Amendment 1754, is Tier B only with a 10-year multiplier of 2.5%. That's $38 million. The third amendment is also Tier B only with a multiplier increasing at 15 years. That costs $26 million. I'm going to ask the committee to vote for that amendment, which is
1757.
I think it's 1757, which is in your book. Okay?
Third one down.
Yeah, the last one on that spreadsheet. So the cost of that is $26 million. It's for those people that were in the system, but not for the people that had not been hired, and it's $26 million. And here's why. I think we made a commitment last year during the budget to try and resolve the retirement, whatever you want to call it, changes that were made in 2011. And I was the sponsor of that bill in 2011. We already made one change in 2022. It was, I believe, House Bill 1587. It cost $43 million. It wasn't enough to satisfy the 1,700 or so Group 2 members. And we have talked about several different iterations of what might help rectify what they feel should have been rectified. I would argue that given our budget situation in an off-budget year, that this is the maximum that we can afford. I have sounded like a broken record during the Retirement Commission that Senator Gray and I sat on. Senator Soucy was also on that Retirement Commission, and talking about the impact of the YDC settlements. If there's anything that has been proven to be correct, it's that concern that the costs of the YDC settlement are going to be significant over the next several years. And our ability to utilize surplus is limited to the constraints that I think we all know that we have to face with a YDC settlement. There are some other appropriation bills that this committee has passed. There are others that the House has passed. But I think that we've been pretty clear that after the YDC settlement, which is probably the top priority, this becomes the number 2 priority. This amendment, and I hope that we can all support it, is what is affordable. I know that there's some concern about not including Tier C. So let me address that. The individuals in Tier C were hired after my bill passed in 2011. So they don't have the same parameters that Tier B have. They were hired after, they knew what they were getting into. I think it is appropriate to think about the impact of different tiers going forward, but I think we also have to consider the overall cost to the state as being more important. Should there be the opportunity to do something in the future for Tier C, that's the time to do it, because Tier C people only have about 12 years in the system now, so they are approaching, but not there yet, okay? So I hope that we can pass this. I think it's something that hopefully our friends in the House can support, and it moves through the process. I think it's, given that we already appropriated $43 million 2 years ago, this is quite fair. And it fits in my opinion, with what we can afford.
I have a question for you, Marty. That's one of the reasons I brought you up. Okay. I'm seeing the 1.6 and the 1.2 million in this sheet that we've gotten. I'm guessing that is the ongoing cost per year from doing this. Am I correct?
You're correct. There is a normal cost increase for the duration of Tier B's working life, and that would drop off when there's no one else working still in that tier.
I've been asked to take a small recess, okay? So we will be in recess for 3 minutes.
Would you say 3 minutes?
3 minutes.
Okay.
All right, I gotta call Nick. My mother-in-law's in the hospital now.
I think that would be great. I'm going to turn off the mic here.
Yeah.
to come out of recess, and we're going to suspend this bill for a little bit of time, and we're going to take up some of the others that are on our to-do list. And, okay, I'm going to the bottom of the list, the five bills that are second committee bills, 450.
Second.
We have a motion for interim study. It's a funding issue that come up with the money. Okay, so I believe,
I seconded.
and I believe that Senator Rosenwald would like to speak.
I mean, I'm going to vote for the interim study because of the cost.
Yeah.
But this is a bill that the Nashua Chamber has been working on for a really long time. I think it's good policy, and I hope it will come back next year in the budget.
I would echo those comments. I think it's good policy, and I do hope we'll see it during the budget cycle.
Okay. Any? Maybe. Is there any more discussion? Seeing none, the motion is interim study. All those in favor say aye.
Aye.
All those opposed say nay. The ayes have it. And who made the motion? Phil made the motion? And he gets to take it out. The next one is 546.
I'll move interim study.
Second?
And there's an amendment?
Not within.
The amendment doesn't matter if you go to interim study.
That's correct.
So-
Thank you.
I understand. Would you want to move on and at least give him another couple minutes? Okay? So we'll hold that motion. It was made by Senator Ennis and seconded by Senator Pearl, but we'll put that in suspension.
Alrighty then.
I've already flipped the page, so we are at 1533.
I'll move interim study.
Second?
Interim study by Ennis.
And again, this is
Pearl.
This is one of those, Mr. Chair, that I think is good practice, but better for a budget.
Okay, further discussion? Senator Rosenwald?
Thank you. This one is not very expensive. The next one is also pretty expensive, but this one really isn't that expensive.
Well, when I'm looking at page 2, proposed safe harbor, I'm looking
1533.
at table 1, I'm looking at table 2. In table 2, cumulative fiscal impact for 25 is $1 million, and for 26, it's 2.1 million. So,
I'm going to vote for the interim study.
You
But
want?
again, I think it's
Yeah.
good policy.
yeah, I agree. Not saying that any of these weren't good policy, but it's, how deep is your wallet?
We have the money committee.
Pretty shallow right about now.
Okay.
This is the safe
1533.
harbor.
Okay, is there any further discussion on 1533? Seeing none, all those in favor of interim study say aye. Aye. All those opposed say nay. The ayes have it. And Senator Bertzold.
You get away with that.
I'm vice chair.
What, did you want to take it out?
1536.
I'll
Can't-
move
he
interim
can't-
study on this one too.
Second?
We don't need him to take them all out.
I'll take this one, next one out. 1536, if it makes the senator happy. Okay.
Well, actually,
You can
Senator
third it.
Pearl already did, but,
Sorry, Senator Diaz,
He gets
quick
one
on the
now.
trigger.
okay, this is relative to increasing the amount of expense deduction allowed against the business profits tax. Any further discussion?
Good policy.
All those in favor say aye. Aye. All those opposed say nay. The ayes have it. And,
Yes, I'll take it out.
well,
Unless
You
Senator
know.
Birdsell wants it.
Senator D'Alessandro was going to second this, so, he doesn't have a
wants it.
bill yet today, so
All right.
we'll give it to Senator D.
No,
Okay.
it is not going to be Senator Innes's day that day.
No, I'm okay with it. I might just speak for the heck of it.
And certainly I encourage you to exercise caution. All right. 1696.
I move interim study.
I'll second that.
Motion of interim study. Birdsong and Innes. Okay, further discussion? All those in favor of interim study say aye. Aye. All those opposed say nay. The ayes have it. You guys want to fight over this one?
No,
now, or-
no, I think Jeb wants it.
Jeb
Yeah,
wants
what,
it? Except
what I
he's up on
would
the
recommend
chair.
is that there's a small cost to this that's possibly funded with ARPA dollars. What I would recommend is when it gets to the floor, we table it so the bill is alive.
Okay.
Okay.
Oh, yeah.
You got to table it?
Okay, well,
Okay.
No, we can't table it here.
No, on the floor. I was just asking if she was going to table it.
If you would rather have the pending motion something other than interim study, you know, we can rescind all the things that we did if we're going to table it.
I think we're okay. I'm good.
Okay,
Yeah.
we'll leave the interim study and we will take care of that. All right, so we're gonna go back to 546 and we held on that because you have an amendment, but the motion was interim study. So I wanted to give you the opportunity to speak against the motion. Senator D'Alessandro would like to speak to Amendment 2024-1881S, but since it's an interim study is the motion that's in front of us, you can speak to it, but it's, you can't make the motion. Okay. Is there further discussion on this bill? All great. Did you want to speak?
Yeah, I mean, same situation with this bill as the discussion that we had on the retirement bill. I think we all know that funding school building aid is a priority. It should be done in the budget. Gutting the education trust fund as, you know, we have uncertain budgeting ahead of us and the litigation, I think, is a bridge too far, especially at $50 million.
Okay. Any further discussion? Seeing none. All those in favor of interim study say aye. Aye. All those opposed say nay. The ayes have it. 6-1. And who wants this one? I haven't taken one out. So I'll take
yeah,
that.
see how you are?
There you go. You know, all right, before I go back up to the top list again, next Tuesday, I don't have a committee in the morning anymore because we did all our bills. Has anyone else got a conflict in the morning on Tuesday?
If we start at 10.
10 doesn't work for Senator Bradley because he's got a standing meeting with somebody in a corner office up on the second floor.
Probably 10:30 would work for me.
Okay, so then we will, what we'll probably try, Jeb, is to have, start the meeting at 11, and that way we can have a Republican caucus right before it at 10:30. And then if you guys want to caucus before it, then that would be fine. Then, you know, we'll break for lunch, and if you want to caucus during lunch, you'll be able to. And then we'll start right back up again at 1, because we're going to have a lot of bills coming off of the
FN report.
FN report onto the committee. Okay, so that's the schedule. And if we don't get everything done on Tuesday, I'll see you on Wednesday. So I mean, we got to get it done.
We have to get it done Tuesday.
We have to get it done
because
Tuesday.
of the addendum.
Yeah. Do I get to?
Gotta have an addendum.
Do I get to stop the clock, you know, when it gets to be midnight? No, no, okay. So we're going back to 1647.
We'll be efficient.
We'll be efficient, okay. Mr. Carlin, I kind of cut you off in mid-sentence. We were talking about whether or not the ongoing cost and the annual cost and the ongoing cost for the first proposal was $1.6 million, and for the second proposal, $1.1 million, and then the upfront cost of $3.82 million and $26,000. Questions from the senators is where we were.
I asked my questions in the off time, so I'm good.
Okay. Is there anything you want to share with us about so that the rest of us?
I was just looking for a clarification between
Sure.
Tier B and Tier C, so I understood, and Marty did a great job explaining it.
All right, so I believe that Senator Innes moved ought to pass, Senator Pearl seconded it, Senator Bradley is moving amendment 1757. And we need a second.
Second.
Okay, further discussion. Senator Rosenwald.
Thank you. I was looking at the projected surplus in the general fund that Mike Kane sent out May 3rd, where he projects that at the end of the biennium, we will have a general fund surplus of $112 million. From that, we have to subtract the $60 million for the Sununu fund,
Yep.
leaving us $52 million surplus. I think we could do the 10-year amendment and still have a $14 million surplus. So I'd like us to do that.
And so you're offering a committee amendment to change his?
No, I'm just saying, I think as a
Okay.
retention tool, I think we can afford the more expensive one.
Then seeing that, we will first take the vote on 1757, and then if that does not pass, then we will go to 1754 if you make the motion. Further discussion? All those in?
So I would just say this, I think, if anything, the $60 million for the Sununu Youth Center is probably the bare minimum of what's likely to happen. I suspect that given the trial, the settlement process is going to be significant, and I think that we will have pressure higher than $60 million, and if we're going to, effectuate the settlements, we've got to be able to have the cash to do it. And I just think that this is fair at $26 million, especially coupled with the $43 million that we appropriated before for 1,700 people. I think it's very fair. So hopefully you can support it.
And as Senator Bradley knows that I'm less enthusiastic about taking Tier C completely out of this, even if I had to move from 15 years to 20 years for that. And so don't be surprised if there's not a unanimous decision on the amendment. Okay, any further discussion on 1757? All those in favor say aye.
Aye.
All those opposed say nay. Nay. And the ayes have it. Now we are on the ought to pass as amended. Okay, further discussion? All those in favor say aye.
Aye.
All those opposed say nay. The ayes have it. And who wants that one?
I'll take it.
Senator, was that a 7?
7-0.
Senator Bertzel, you're gonna take it out?
Sure. Okay. Thank you, Marty.
Thank you, Marty.
All right, we're on House Bill 1678.
Who ought to pass?
And
Second.
we have a motion of ought to pass. And we did have the hearing on the amendment, but during that discussion, it was discussed that we might put that off. Now that we've got a hearing, it would be germane for something else without objection. Is there any discussion? Who made the auto pass motion? Senator Pearl and Senator Bradley made the second.
Mr. Chair, I would just say that these school to farm to school programs should provide the kids with some very good locally grown nutritious food, and I'm glad we're able to support it for pretty small money.
Okay. Further discussion? Seeing none. All those in favor say aye.
Aye.
All those opposed say nay. The ayes have it. Senator Pearl,
I will take that one.
you get that one. Okay. So, on your list, the two that are still hanging out are 1583 and 1593. Okay? For anybody that didn't hear, we're going to start at 11 o'clock on Tuesday. We'll work for a little while, and then we'll let you get your lunch. I don't know if Senator Bradley's going to have a leadership meeting that I would have to attend, but then we'd be back here at 1 to continue on, and everything has to get done. Okay?
Do you know how many we have next week?
I can tell you that there was 37, I think, that I took, and then we've added additional ones on there. Several of those are inexpedient to legislate, on the calendar. And it's always fun when we get amendments to tack on to different things. So, that will be part of the business.
Will you be providing coffee?
Will I be providing coffee? I'll tell you what, I'll provide the water for the coffee.
It's gonna take more than M&M's.
All right, do I have a motion to come out of executive session? All right. All those in favor of coming out of executive session, say aye. All those opposed, say nay.
Yeah, do you wanna do?
Our business of the day being complete, we are adjourned.
Should we do a little coffee?
Yeah.